I'm Theodora Mantzourani. I'm a medical doctor from London, mainly involved in management of obesity, diabetes, with a special interest in endocrinology, but also I am involved in anti-aging. Obesity, it's needless to say, it's a major problem. It's gaining epidemic proportions, and it has doubled since 1980. And as you can see, it's mentioned here that basically in the part of the world that we mostly of us live in, obesity kills now more people than undernutrition does. And apart from the toll on health, it's putting major burden on healthcare costs, which are on the increase because the majority of the population that gets sick nowadays are obese people. Obesity is preventable, that's the main thing. So as clinicians and scientists, we have a responsibility to tackle it before the complications arise. Sugar is the main refined carbohydrate that as clinicians we always like to talk about, and we warn people to stay away from. So now the WHO, but also other major institutions such as the American Heart Association, also the guidelines for Americans from 2015 to 2020, they just recommend adults to keep sugar intake lower than 10% and ideally less than 5% of the total calories, daily calories. One of the major complications of obesity, needless to say, is the metabolic syndrome, and there are very robust criteria for the metabolic syndrome. I'm sure you're all very much aware of them. Obesity is associated with other morbidity as well, in major organs, as you can see. I'm not going to mention all of them, so you can go through the slide. It has lots of economic repercussions with reduced productivity, unemployment, and direct healthcare costs. I'm going to mention the 2.6% for the UK public health spending, which is a major burden and strain on the national healthcare system for the UK alone. Also very important, and we can't really go without mentioning that is the cancer associated with being overweight and being obese. There are 13 types of cancers associated with breast, bowel, and uterine cancer being the major associations with obesity, and others being studied. Now, what do we have in terms of management? Okay, it's like a pyramid for us clinicians. It all starts with lifestyle modifications, as we all very well know. So it's primary dietary modifications, exercise prescription, and some behavioral modifications, and then we go to other pharmacological and then bariatric. So before, just for your reference, Wadden and all, in a very nice article in circulation, has this very good, comprehensive table about exercise, diet prescription, and behavioral therapy prescription, both for weight loss and weight loss maintenance, which is even harder to achieve than weight loss. So this is very comprehensive, and I thought it would, it looked good because it's quite specific, can be applied. But I'll just go very briefly through each component. So in terms of diet, okay, so the diabetes prevention program showed that participants with impaired glucose tolerance, randomized to lifestyle modifications and metformin, actually managed to achieve better outcomes and a reduction to progression to diabetes on the lifestyle arm compared to metformin. So that was an amazing outcome. What is the best diet? There is lots of contradiction about that. Actually, the consensus is, from what I've read and know, that the best diet is the one that somebody can follow and stick to. And this is actually what we should strive as clinicians to identify. There are different patients, different preferences, so different lifestyles. So we'll have to work around the patient. So it's very much a personalized choice. However, there are studies that show that low-carb diets are associated with a faster initial weight loss, which might increase motivation. So that's one thing to think about. But low glycemic diets and low carb, as opposed to just hypocaloric or low fat, have a better improvement in HbA1c and lipids. Okay, so that's something to remember. Now, exercise. I think exercise has been overrated when it comes to weight loss as an initial strategy, and the consensus, and even confirmed in a recent position by the American College of Sports Medicine, actually concludes that it's not that important as an initial weight loss strategy. So diet is far more important, but it's very, very important for weight loss maintenance. Okay, so it's something to remember. And so for people who have managed to lose weight, as per the National Weight Control Registry, those people have certain characteristics, one of them being maintenance of a high intensity exercise, or like, for instance, at least 60 minutes per day of brisk walking. Okay, so exercise is important for weight loss maintenance rather than weight loss. Behavior modification is very important. Whatever strategy we manage, to implement, we have to change the attitude to food. So therefore, participants should have support during the weight loss procedure, and also, throughout weight loss maintenance. And that can take on different, forms. So that was very, very well, in my opinion, elaborated in the table. So moving on to pharmacological treatments, I think this is beyond the scope of this presentation. I'm just going to mention them in passing. There are currently 6 medication options available, FDA approved. In the UK, there's just one, so the only one that is, universally, from my research, approved for weight loss, and now it has even been approved as an over-the-counter supplement for weight loss rather than medication, is Orlistat, so a lipase inhibitor. The rest of them, phentermine, topiramate, naltrexone, bupropion, liraglutide, okay, GLP-1 analog, they are the main 6 medications that have been FDA approved. The American Heart Association and also the Endocrine Society guidelines suggest that the pharmacotherapy should be considered as an adjunct to lifestyle and behavioral interventions in patients with a BMI of more than 30 or BMIs more than 27 with comorbidities. So there are eligibility criteria for those. Bariatric surgery, which is the top of the pyramid. So let's say that, pharmacotherapy and lifestyle modifications have failed to lead to weight loss. There are strict eligibility criteria for bariatric surgery. So for BMIs more than 40 or BMIs between 35 and 39.9, and some comorbidities, and of course no response to non-surgical interventions including lifestyle, we need then to consider bariatric surgery. Moving a little bit forward, what about plant dietary supplements for obesity and diabetes? I'm going to talk a little bit about the 3 main ingredients in Tribitor, which is white bean extract, mulberry leaf extract, and chlorogenic acid later on. So the white bean extract from white bean, okay, Phaseolus vulgaris, has been promoted as a carb blocker. So it inhibits amylase basically, and the RCTs showed reductions in fat mass and weight. The doses were variable. Obviously, my colleague, the lead scientist, is going to tell you about the exact, dose that has been proven to be efficacious in the supplement. A meta-analysis showed reduction in fat mass only, but not in weight. Okay, no significant side effects. So across the studies, there have been nothing, no dropouts from the clinical studies. And the mulberry leaf extract, which is my favorite from what I've read, again promoted as a carb blocker. It inhibits alpha-glucosidase, so the disaccharidases in the brush border enzyme for the absorption of disaccharides. So the RCTs in impaired glucose tolerance patients reported improved postprandial glycemia, okay, which is expected. Alpha-glucosidase inhibitors are very promising in pre-diabetes, and therefore the mulberry cranberry leaf extract, which can do exactly as well as acarbose, but without the flatulence and the very, very common GI side effects of acarbose that limit their use in clinical practice. So therefore, it's one of my favorite plant-derived supplements. Also, it was shown to promote a better glycemic control in healthy individuals without an impaired glucose tolerance. So chlorogenic acid, which is the green coffee extract, again, lots of hype about it and lots of supplements. It works by enhancing glucose tolerance, insulin sensitivity, and the main actually, because the mechanism of action is quite complex from what I've researched, maybe the main one is attenuating the absorption of glucose from the small intestine. So it has a strong, like alpha-glucosidase action as well. So this is the results of included RCTs on chlorogenic acid, and the outcome of that, if you look at the numbers, is that using it between 4 and 12 weeks has shown a significant weight loss, which is about 2.5 kilos, okay, which is quite promising. Now, I'm going to pass the ball on to my colleague, Dr. Kasia Marjak. She's the main scientist involved in the clinical studies on Tribitor, so she's going to give you the latest. Thank you very much.